Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week we talked to Dr. David Schwartzberg. Dr. Schwartzberg is a double board certified colorectal surgeon with expertise in inflammatory bowel disease, pelvic floor conditions, reoperative colorectal surgery, as well as robotic laparoscopic minimally invasive procedures. We talked to him about why he chose to become a surgeon and his passion for helping people as a career. We talked to him about his passion for inflammatory bowel disease and inflammatory bowel disease surgeries and helping people with J-pouch conditions. We talked to him about complications that can happen with surgery and how they can be fixed or improved with additional surgery. We talked to him about upper GI Crohn's and also about J-pouch failure and what you can do about that. We had such a fantastic conversation with Dr. Schwartzberg. He's awesome. Enjoy. Cheers.
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia, and we are absolutely delighted to be joined by our guest tonight. Welcome, Dr. David Schwartzberg, to the show.
Thank you for having me.
Our very first, very unprofessional question for you is, what are you drinking?
Yeah, so I knew that was going to be asked, so I thought about it. I don't drink often, but when I do, I'll drink a whiskey. And so this is a Macallan that I was given by my father-in-law for some holiday. And he said, oh, I got this at work. It's like a really good one. And he gave it to me. And then he Googled like how much this bottle, it's like a $500 bottle. And he's one of the sweetest human beings I've ever met. And you could tell for like a split second, he was like, can I have that back? and so in his honor, we've only like open, you don't have to look at it. It's like in Spinal Tap with that. He's like, don't look at the guitar. And he's like, don't even point at it. I'm not going to play it. And he goes, okay, we're done. So I feel like in honor of him, I figured aged 20-year Macallan.
Wow.
What are you all drinking?
So even though it's the evening time, I still have a work call after this very late at night.
So just Scotch. Okay. I got you.
Just straight Scotch. I'm actually drinking fancy foo-foo coffee.
I was really excited to discover that Topo Chico makes a seltzer now. So I'm drinking their strawberry guava one today. So cheers. Thank you again for joining us on the show.
Cheers.
Next question for you, Dr. Schwartzberg. What is your IBD connection? What brought you into our community?
I always wanted to be a surgeon, but I had a great experience at Sloan Kettering, and I really wanted to be like a recurrent cancer surgeon and kind of take on the most complicated cases. One of my earliest mentors was Dr. Philip Patey, who's still there, and he's amazing. And he's amazing with the patients, and he's an amazing teacher. And he did these cases that, were people's last shot, where a lot of other people would have given up. And he says, let's do it. And these cases would take, 15, 16 hours. And I thought, this is what I want to do. I want to be, it's, I guess you have to be a little crazy or have a little bit of an ego, but it's not that for me. It's just, I really believed I could do it. And I thought, well, settling for anything short of that would be it's not fair to whoever may need my help. So I have to try to be the best. I have to try to study the hardest. I have to try to, my surgical skills and all this stuff. And so I thought that's what I could do. But then I realized there's a lot of people who do a lot of great cancer surgery. But when Feza Remzi came to NYU when I was a chief resident and showed me, how few surgeons have specialized in inflammatory bowel disease surgery, which is really difficult, and how much you can improve someone's life if they have the proper surgery done properly at the proper time. And what's nice about it is, and I come from a long line of like medical doctors, like on the medicine side, you really have to know a lot about, it's not just all surgery. You really have to know what's going on in the medical side of things. So you have to be more of a medical surgeon because you have to know what's out there. And it really makes you interact with the dietitians, with the stoma therapists, with the gastroenterologists, with the interventional gastroenterologists. You have to kind of know where everyone is because it is a team approach to inflammatory bowel disease. And I said, this is exactly what I want to spend the rest of my life doing. And so there's not even a personal, connection in terms of anyone in my family who has it. But it's just, I see the resilience in some of the patients. And I just think, they need someone to truly care. And actually, when it's time to go to the OR, actually knows what they're doing. And it's humbling because there's so many things that are changing all the time. But I mean, it's truly, besides my family, is all I care about. That is entirely truth. And it's wonderful to get to take care of people and to take care of people who've been told, maybe, no offense to anyone, by like local surgeons or kind of, oh, there's nothing else we can do. And it's nice to be able to say, no, let's go for it. And as long as we're safe, obviously, but let's go for it. And let's give you another shot. And it's a nice thing to be able to give that to someone, give them back their life and, let them go back to what they enjoy doing. And it's a nice feeling. It really is.
As a patient who's had multiple surgeries, it's nice to have someone say, let's take a shot, because I've been told that. Let's give it a shot. Do you want to give it a shot? We'll give it a shot. And so having another option out there it's nice to know that there's the possibility of that. So thank you for continuing to work and learn and study and be the best. We appreciate it.
Well, we're certainly trying, but yeah, I think it's important. I think there's a lot of people, even with things like diverticulitis, things that can be complicated, but is not such a mystery. Someone may have like an emergency colostomy, and then, they're young and they could be like 60, that's young. And so, but then the local person says, you got to live with it. It's too risky to reverse. And you're like, wait a second, it's not true. Certainly if someone has real risk factors, like they had a heart transplant, the heart's not doing well, there's risks and benefits. But if it's safe, there's no reason why, someone's skill or opinion should impact someone else's wishes. And so, even little things that patients have been told, no, there's nothing we can do. You got to live with it. I kind of joking, I'm tongue in cheek saying it, but on some level, I mean it. Until I've said it can't be done, then there's no reason that it can't be done. And not just me, but, there's a group of people, other surgeons that I really respect, one of, being my mentor. But, I figure we get paid to do, like Mariano Rivera, who was on the Yankees, he didn't get paid to pitch the first few innings. He got paid to pitch the ninth inning. He got paid to pitch at the end. He took you home. And I feel like that's what my paycheck's for, is to take those not, they're calculated risks, but to take those risks on behalf of the patient.
This is one of the reasons why I wanted us to bring in professional guests when we talked about doing the show, is because I absolutely love, and I know Robin agrees with me, meeting people like you who say, this is my passion and I know I can make a difference. So thank you for that, number one. And this is because it's just just delightful to hear from people like you who say, I want to do really good for this community and I know that I can. One of the reasons that we definitely wanted to talk to you is because you do tend to take on these very complicated cases, and some of these cases that are a little, from people that have heard no, and including some J-pouch issues and stuff like that. I mean, one of the things that you wrote that you really wanted to talk about is, how do you work with patients that have had surgery that have maybe then had complications that now need to figure out how they can improve their life, or sort of quote unquote fix some of the things that may have happened in past surgeries. Talk us through a little bit about that. Like, somebody comes in the door, they're having some complications. What's the first thing you do?
I mean, even myself, if I have a patient who's maybe not doing as well as I think they should be doing in my hands, because these things, surgery is very humbling, and the best of intentions, the best procedure intraoperatively, everything go perfect, and yet things still happen. So, we all have our complications. And I think to myself, and this is what I, was taught, what I have come up with it myself on some level, maybe, but what I was taught by my mentor, which, was taught by his father, who was also a surgeon, I'm talking about Dr. Ramsey, is, look at your own footsteps. And, is there something you could have done better? Was there something that went differently? And sometimes the answer is no, but a lot of times you can think, I wonder if it was this. And I think part of putting your ego aside is, even if there is a complication, being able to say to the patient, listen, this is what I think happened, and I'm here for you, and I know what to do. I'm going to get you through this, recovery phase, but I'm here with you. And I think sometimes, as surgeons, at least what I've seen, and I think, you can be guilty of it, and I try to actively fight that, is saying, oh no, everything's fine. And I don't think that way. And so when someone comes to me who's having some issues, I think first you have to listen to exactly what they're telling you and the timing of what's going on, because you're starting to think, and it's nothing to do with the other surgeon. I would think the same way on a case that I have done. Okay, what little detail, what was it? Did someone have a very risky operation in the setting of malnutrition and steroid use, and even biologic, and maybe didn't have a stoma when they maybe should have had a stoma? And maybe, so I'm thinking, okay, maybe they didn't have a stoma, maybe there was a little leak, because there's all these risk factors, malnutrition, steroids, maybe there's a leak. Okay, so it's like Sherlock Holmes, you have to that little clue, and you say, okay, let's investigate, let's see if there is a leak. And then you do whatever test you need to do, and you try to prove to yourself that's not the case. And then fine, it's not. And you go, okay, well, let's see, this person's got having these symptoms, kind of sounds like it could be some kind of, maybe it's adhesions causing a partial bowel obstruction. And you go, well, look at the imaging. Well, there's no bowel obstruction, but I see there's this type of, when they did that small bowel connection, which we call an anastomosis, they did it in kind of a funny manner. And maybe that's the problem. Maybe it's not functional. So maybe it's not narrowed, but it's causing symptoms of something that's narrowed because it's not functional. Okay, let me figure that out. If you run out of things to disprove, you go, okay, I think that's what it is. And then you tell the patient, listen, here's all the things that I thought it was or could be. And here's why I now don't think it's any of those things. And here's why I do think it's this thing. And I think if I can fix that one thing, I think you're going to be better. And one of the things is that kind of, I think when you start to think about surgery and reoperative surgery or corrective surgery, which is sometimes what we call it, is patients who have J pouches and or just not doing as well as they should. And when you finally get to the point where you're in the operating room and you see something that maybe some of the rectum is left where it shouldn't have been left, or there's this honest to God twist in the pouch. And we're seeing more of that with minimally invasive surgery, but there's something there. It's in front of you and you can fix it. And so when you start to then look back at what brought the patient there, and you're going, wow, for 2 or 3 years, this person said, I'm not feeling right. I can't X, Y, and Z. And then they finally come to you and you're like, oh, let me do, this test and that test. And within a day or two, you're like, oh, I see what's wrong. And it breaks your heart that someone for years was screaming, I'm in pain, something's not right. And everyone's going, I don't know, it looks fine to me. So when you feel like you can, figure that stuff out, if that's how you think, it's kind of like Sherlock Holmes. I love those movies. Actually, Sherlock Holmes was written by an author, but the person who wrote, he was actually a doctor. And that was kind of what he wanted to portray, was like these little details, especially back in the day when doctors would, sometimes lick or smell or taste urine to see if someone had diabetes. And, you really kind of had to really, get in there. And so if you say, I can figure these things out, at least I'm trying. I've seen what can happen. I see what we can fix. You kind of then want to say to people like, here, come to me. And so it looks like you're saying it because, you want to be like well known for the sake of being well known, but you're really like a lighthouse. You just want to like hold a light up and say, come, or even, France's gift to us, the Statue of Liberty, we were talking about that before. No, but it's true that, she has this light and it's a beacon of hope. And that's what it is. So you want to say, listen, I can do these things. If you're not feeling right, if no one has been listening to you, please come see me. Let's at least give it a shot.
That's what it is. It is definitely a beacon of hope because so many of us, honestly, you start to feel like you're going crazy. You get told that there's nothing wrong with you for so long. And then you're like, okay, am I crazy? Like, am I making this up? So having someone who's at least willing to listen and then explore, at least willing to take a look to say, okay, let's see if there's something, it makes all the difference. Honestly, it just acknowledges that there could be something. It changes everything.
Yeah, there's this quote, I think it's by Albert Einstein, but it says, I'd rather be an optimist and a fool than a pessimist and correct. There are, not in the IBD population, but just as humans are, there are some people who, are drug seeking, and there are some patients who aren't, that's the way it is. And I'd rather be fooled by them by taking, even the I think that's very few patients, because I think in most patients who like, maybe I've had a consult, they're like, oh, there's someone in the ER, they're always here, they always say they have abdominal pain. You kind of go to everyone rolls their eyes. And I say, BS. I believe everything this person says and operate from that assumption. Everything they say is correct. They're not lying to you. And again, I'd rather be duped by someone than to, God forbid, not take someone seriously who actually is in pain and needs our help. So that's just, once you make that decision, that's your decision. That's your thought process.
That's a really important thing to say. And I think that's an important thing to remind people, that the humanity side of that, because, this does affect a lot of people with inflammatory bowel disease. Unfortunately, abdominal pain is the thing that usually gets you the card that's labeled drug seeker or frequent flyer in the ER. And those are the people that go longer without pain control. Yeah. And women go even longer than men without pain control.
And just because someone didn't know where to look, right. So then they say, they're making it up. And it's like, that's not fair. I just don't believe that.
No, it's not only that. You can't even get pain meds. Mm-hmm. My primary care can't prescribe pain meds. My GI can't prescribe pain meds. My rheumatologist can't prescribe pain meds. Nobody can prescribe pain meds.
How is it possible a rheumatologist can't either? Like, that one seems real bizarre to me. Wow.
That's a good point.
Like where I live, I have to go see pain doctor to get pain meds. And so not that I need them right now, I don't, but I'm just saying I want to get in to see one now because it's been months, I haven't been able to get in to see one to set up as a patient in case I do need it because I have Crohn's. So I probably will have pain again in the future.
Speaking of Robin's Crohn's, though, I'm sorry, I'm going to pull us back a little bit here because Robin, she's one of those folks that like she had initially was diagnosed with ulcerative colitis.
Diagnosed with ulcerative colitis 2000, had surgery right away for my colon to be removed, had an ileorectal anastomosis, had that for 20 years. In 2018, my diagnosis changed to Crohn's and Crohn's showed up in my stomach. In 2020, I had a J pouch built. In 2021, had my ostomy takedown. So I've just had the J pouch since December of 2020, functioning J pouch takedown since July of 2021. But I've had IBD since 2000. But
I feel like we've heard from more than a handful at this point of people who have started out with a diagnosis of ulcerative colitis, had J pouch, and now it looks like it's Crohn's disease.
We do see that. And there's like this gray area between patients who have ulcerative colitis and have a J pouch, and then something goes wrong with it, such as maybe there's a leak. There's usually something that happens when you see someone, you go, okay, you're not doing well. Tell me about the surgery. They're like, oh, I was supposed to have my ileostomy reversed, taken down, at 2-3 months later, but it was almost a year later because I kept having to go back for procedures. And you're like, wait a second, tell me about that. And they think there was maybe a leak. And you're like, you start to raise these, these flags and these little red flags. And now you're seeing someone and they go, well, so, I have Crohn's disease because, I have a fistula. You're like, you might, but it's almost more likely that this happened very recently, that there was a problem with the J pouch. Again, in best of intentions, but you can have a leak and then this leak never fully heals. And then it causes symptoms that look like Crohn's. So there's a lot of people who have symptoms of Crohn's of the pouch. They don't actually have Crohn's of the pouch. They have kind of an anatomic, mechanical, post-operative issue that looks like it's Crohn's disease. And so there's a lot of this. But what happens when someone, has some issue like that? Everyone says, oh, it's Crohn's. So what do you do for Crohn's? You start someone on a biologic, right? And so now the person really needed maybe, antibiotics and maybe taken for an exam under anesthesia and, figure things out. But the diagnosis, at least because of a few symptoms, starts to change to Crohn's. And then it goes down a different pathway entirely. So we do see that. But even ulcerative colitis, there's some new studies saying there can be inflammation of the stomach with ulcerative colitis, where typically people, they said, well, if you have inflammation elsewhere other than the colon, it's got to be Crohn's. It can't be ulcerative colitis. But I think even more than that, whether it's Crohn's or ulcerative colitis, what part of the body it's affecting is more important. So, so the people who do worse are people who we think it's ulcerative colitis and it turns out it's Crohn's for some reason, where patients do best if it's ulcerative colitis and they get a J pouch. And the people who do second best are people who we know it's Crohn's disease, but they can get a J pouch. I think it's because everyone's just much more aware of looking for these symptoms early on. And then the people who do third best out of three is the people who have indeterminate colitis or what we think is ulcerative colitis. And then it turns out it's Crohn's disease. So it's one thing if you're going into a J pouch surgery knowing it's Crohn's disease. It's another thing if it's ulcerative colitis and there's that third category, we're not sure. But, a lot of postoperative issues manifest looking like Crohn's disease because that's what everyone says, right? They're like, oh, it's Crohn's. Like if you don't know what it is, you just blame Crohn's and this, everyone, oh, there's a stricture. Oh, it's probably Crohn's. Oh, there's a fistula. Oh, it's probably Crohn's. Oh, there's chronic pouchitis. It's probably Crohn's. It could be, sure, but it also might not be the underlying reason that someone's has, let's say, chronic pouchitis. It could be that there's a small leak that never fully healed and just kind of keeps, you could put on antibiotics, the leak gets a little better. You get off the antibiotics, that little abscess gets a little worse, it inflames the pouch, get pouchitis again. Now you're labeled as, oh, you have chronic, refractory pouchitis. And that could happen. That does happen. But in a lot of people, there's something else going on that needs to be worked up. And if all those things are negative, then fine. In my opinion, fine. Okay, you do have, chronic pouchitis, sure. But until a mechanical, technical, postoperative kind of complication, even though that, no one's fault, until that's worked up, I feel like you shouldn't just immediately label someone as having Crohn's disease. In many scenarios is what I see kind of doing this reoperative surgery.
What are some of the most common pouch issues that you find in some of these folks that come in that are like either seeking a second opinion or just like, their doctor has said, I don't know what to do with you?
There's a few. And I'm working on an article proposal that I'm hopefully going to submit to be presented at a great conference, which is every year in Disney. And they have like regionals, and it's advances in IBD, AIBD. And it's kind of looking at even abdominal reasons that people have. Patients with pouches are quote unquote labeled as pouch failure. But a lot of times, and my mentor, would say, when people have an ileostomy to protect the pouch, then you take that ileostomy down. That ileostomy has to be sewn together end to end, putting it back together, where people most of the time do, because it's a little quicker, it's a little easier, faster, is do a stapled anastomosis, which is when these two ends of the bowel are like laid side to side and a common channel is created. But it has a lot of functional problems, and it can be stenotic. And so patients have this chronic abdominal pain. They're nauseous, and it's not even their pouch. It's actually happening before their pouch. It's happening in their abdomen. So we see a lot of strictures at the ileostomy site, the old ileostomy site. And we see a lot of strictures at the anal anastomosis site between the J pouch and the anus. And a lot of that is because of tension. And so especially if you see someone who had a 1-stage or a 2-stage J pouch, meaning their colon and rectum and the J pouch was made all at once, that a lot of times if the colon was removed first and then you came back later to take out the rectum and do the J pouch, it allows the bowel to elongate, and there's tension. So tension, what we see a lot is tension on the anastomosis for a variety of reasons. But if there's tension on the anastomosis, the result is a stricture. And so a lot of patients come in with a very narrow, anal canal essentially, and they have to go through serial pouch exams and this and that. And then sometimes these pouches are twisted, or they're half twisted, and they're not emptying correctly. Really, the ideal scenario is, small intestine going straight into the pouch, going straight to the anus, and everything's got to be in a straight line. And when things start to be a little off axis, it really messes with the kind of the physics of tubes and pressure and things that are moving, and things can kind of create that ball valve effect where someone goes to evacuate and they go to, they push, but what it does is kind of cause something to close, and only a little bit, like a car accident, like in front of the car accident, like everything can move, but behind the car accident, everything's blocked. And so patients have these kind of very unusual, sometimes obstructive symptoms. And it's sometimes explained by, a very obvious thing. The hard part is how to fix it, because, really to redo the pouch is a big, big deal. So we try to do whatever we can on a smaller local, procedural surgery kind of level to avoid that. But ultimately, sometimes people do need that.
I guess I'm curious if there's a reason. You mentioned them doing like the stapling together the two ends and creating a new sort of common channel. Is there a reason other than just not wanting to keep people under anesthesia for a certain amount of time? Like, why would somebody take that shortcut if they don't need to?
Honestly, it's a little bit that it's a lost art in many ways.
Okay.
It's a little bit of time. And there are some studies showing that the patients can leave the hospital a day earlier. So they're after an ileostomy reversal that's stapled, their intestines wake up a little faster. So you're like, oh, that's good. Get them out of the hospital. But if your metric is getting people out of the hospital and that's what you're going for, then that's what you'll get. But if your metric is thinking 2 and 3 steps ahead and making sure I don't care, if someone stays an extra day, I want it to be done properly. That's a different metric. And sometimes it's skill, sometimes it's patience, sometimes it's time, or simply training that some people don't have. But, you beware of, people who care too much about money and power, because there's a Rudyard Kipling quote that says, like, don't be overly concerned with money, power, or wealth. One day you'll meet someone who doesn't care for any of these things, and you'll realize how truly poor you are. And so I don't care about money per se. You need to have some in the world, but that's not. And if I'm at a hospital system that only cares for that, then that's probably not a good match. So I'd rather let someone stay in the hospital an extra day, knowing that I've done the right procedure down to the very detail, even if it takes a little more time, because I know in the future that's going to be better for the patient. And so, but there's a lot of, I don't know, you can only, control what's in your universe. And every time we give a lecture to surgical residents or fellows or anyone else, my mentor and I always try to stress the point that a patient needs to have a hand-sewn closure. And the same goes with Crohn's disease. If you're resecting small intestine, this end-to-end connection is like how God created it, right? But on the side to side, it takes a certain amount of bowel in each direction. And so if someone has a recurrence of Crohn's disease, not only do you have to take out the recurrence, but you also have to take out that anastomosis. So you just lost an extra 15 centimeters of bowel for each recurrence for no reason. And if maybe someone has a few recurrences, they haven't infused spots, next thing you know, you add this up and it's 100 centimeters of bowel. And that might be the difference between, short bowel syndrome and not. And so as my mentor would say, thinking 2 and 3 steps ahead, that's the art of it. The art is thinking 2 and 3 steps ahead. So we try to always do whatever's best long-term, not exactly what's going to make, the person just get up and out of the hospital and make the hospital money. That's my opinion on it.
Open that bed up faster. Yeah. I'm going to ask you a real question in a second, but I am curious if there was anybody that you knew that was advised not to be a surgeon because their sewing sucked so bad.
No. But there's certainly some people, I think about it like art, you can take all the art lessons you want. There will always be Picasso, right? I mean, this guy he just knew what to do. And so there are certainly varying degrees of kind of artistry and surgery, but the training is so long and so hard. And there's so much emphasis on, surgical skills. And we have like skills labs where you practice this stuff, that there is certainly a layer where everyone is good. Everyone is good. Some people might have that touch, but no, I think if you can get through, by the time you graduate, I think everyone knows what they're doing. Thank God.
They don't have you take up like embroidery on the side just to like improve a little bit.
No, I try to do that. I sew. I'm the sewer at home. Like my kids have their little stuffed animals they've had since, they were like infants, and the ears and their heads fall off. And I'm constantly, vicral suture is kind of like a braided suture. It's kind of similar to like a sewing. So and I'll take a suture home from the hospital, and my son has Eggie, and Eggie's basically entire head and nose and ear is all like a vicral suture that's been tied. And so yeah, but I do think like that, any practice you can have. And sometimes I play music, instruments, whatever I'm playing, just because I'm on some level, it's about muscle memory and kind of being connected to your hands, and anything that can improve that, and any practice you can with your hands, I think is important, because this is a craft. Surgery is a skill. It's a craft. You're not a professor, you're not just giving these long sermons. It's important. We at the end of the day, what you do in the operating room matters. And so I think anything, I watch surgery videos of operations at nighttime, but like, of course, right? That's what, if you're obsessed with something, that's what you do. There are people who are obsessed with baseball and they watch old reruns of Yankee games, even if there's a rain delay, that's what they do, of course. And they spend Saturday watching college football. Like, if that's truly what you care about, just so happens that truly what I care about is surgery. And so, it's a good obsession to have, essentially.
Here's your real question, especially considering some of the folks that you're seeing have had perhaps poor response to the surgery that they have gotten. And so they've probably been symptomatic for even longer. I'm curious how you work with them to get them as optimized as possible for success in their surgery. Like, what are some things that you do to really try to make it so that as people are either going through like another surgery, like to get a replacement J pouch, or what are some things you do ahead of time so that that when they are laying on the table waiting for you, that they're in the best possible place they are? Like, how do you optimize things for them?
Yeah, I think it's a great question. In short, you want every modifiable risk factor, is what we say, like, at these surgery meetings, every modifiable risk factor to be modified. And so if someone's smoking, that's an easy one, right? But you got to stop smoking. That's what you say. If the truth is, sometimes in J-pod surgery, if someone is obese and, it's common, we say, we need to at this particular weight, and it actually does affect kind of the reach of the intestines. If someone can't eat, we try to meet with the dietitian, nutritionist, see what they can tolerate, how much protein, how much good food can we get in them that's not going to cause pain or a blockage or something to that effect. And ultimately, people may need either, one of two things or both that we do try to avoid. But sometimes, you can't, like an ostrich, put your head in the sand and just pretend it's not happening. You need to make every risk factor in your favor. And so if someone needs like an ileostomy or even a jejunostomy to allow them to eat and gain weight because you're not ready to do that complex surgery yet because there's something bad going on lower in the abdomen, or if someone needs, or both, or someone needs TPN, which, total parenteral nutrition, TPN is IV nutrition, and you need a special IV that gets put in. That IV is associated with blood clots where the IV is, associated with infections. And knowing these risk factors, it can cause issues with the liver. There's issues with glucose and blood sugar control. But at the end of the day, if someone has a problem and you can fix it, and as you said, you have to get them in the best shape possible. I always think about like the week before the Olympics. These athletes are the best shape in the world. That's what you want to be in going into these big surgeries. So sometimes patients need a surgery, like just to have an ileostomy or jejunostomy, just to set them up for a future surgery, or we do have to put them on TPN. And every other thing, if there's infection, antibiotics. If maybe they need an IR drain, which is a drain, that gets put in under ultrasound or under CAT scan to drain that infection. So if there's infection, deal with it. If there's malnutrition, fix it. Even if someone is very frail, try to get them on an exercise program. Try to get them like the Olympic athlete at the Olympics. They're in their, they might not be Olympic, ready, but to them, the best they can be, because that's going to ultimately give them the best shot at, having a smooth surgery and a smooth recovery.
So say somebody's like mid J-pouch surgery, like you've created the pouch, you're sort of waiting for things to heal before you reconnect. How are you gauging that success at that point? And then like, what happens if somebody comes in and they're like, you think they might be ready, but then they show up and you're like, oh, what the heck? You're not ready yet. How are you gauging that?
Well, I think in many of these scenarios, there's what you assume will happen. And then you're all those normal things kind of happen naturally. The patient had a J-pouch. They left the hospital in a few days. They're already used to having the ileostomy, because let's say they had one before when the colon came out. So you see them in the office. They say, listen, I'm doing well. And you say, okay, well, I'm going to get a gastrograph and enema, a GGE, which is when we make sure all the connections are open and nothing's leaking. And it comes back normal. You're like, okay, let's reverse you at, somewhere between 8 and 12 weeks. And then there's the patients who, had an issue afterwards and maybe had an ileus. So their bowel didn't wake up right away. And then you got a CAT scan and there was some fluid and maybe they needed a drain. Maybe they stayed in the hospital for an extra while. So right off the bat, as long as you're receptive and kind of looking at things, you'll see, okay, maybe this person isn't ready yet. Or, you know what, let me get a CAT scan. Okay, maybe this resolved. Let me get that gastrograph and enema. Let me really make sure everything's okay. Maybe there is a little leak. And you say, hey, listen, there's a little leak. We did everything we could. 99% of the time, all we have to do is wait a little bit. And so it stinks. It stinks for the patient much more, but it also stinks. It breaks your heart as a surgeon to say, because this person is like, okay, I've been through so much. I thought I was going to have my pouch and, the ileostomy was going to be reversed. That was supposed to be the easy part. And you're going, but you got to hold on to that ileostomy for a little longer because, there's a little leak and just wait. Just give me 6 weeks and we'll redo the gastrograph and test. And, it's better, but it's a little smaller, but give us another 6 weeks. And, sometimes it does turn into, 6 months or even a year. And it may be in some patients, and it's very rare, some patients never even have the ileostomy reversed. They have to go straight into a redo J-pouch procedure. And it's rare, but again, the important thing is not to be like the ostrich and just pretend it's not happening. You have to just see what's going on with the patient and, deal with it and just be honest with them and tell them you're there for them. You'll get them through it. But unfortunately, we're going to go on a little bit of a detour, but it does happen. I think, again, it's just important to pay attention to all these little signs like Sherlock Holmes.
Okay, I am going to change directions here and I'm going to make this all about me now because I have Crohn's in my stomach. Yay. And I've been told many, many times, pretty much every doctor who I tell that to says, oh, that's rare. Yes. Oh, so but I know that you've done a little work around that, research into that, looky-loo into that. So can you tell me about it? All I know is that it's rare. Because it's rare, there's not too much information out there about it.
No, it's honestly that is rare. No, I'll elaborate. Thank you. I'll be here all night. Tip your waiters.
Yeah.
Okay.
Back to you, Alicia.
It's interesting. And again, when I was a fellow at Cleveland Clinic, we tried to kind of look at this where I think still probably going to try to write it up, but try to just get some more patients that are enrolled, but it really is rare. And a lot of the studies, so I wrote this like very long article on Crohn's of the esophagus, of the stomach, and then of the duodenum, which is the first part of the small intestine. And a lot of these studies were old. A lot of these studies were when there was only prednisone to treat these things. And a lot of them kind of resulted in these surgeries. And I think, we kind of have to redo all of these studies now that we have such strong and plentiful biologic medications. And it's something that, I have this whole theory about fecal stasis, which is something I think about a lot. And I think that's why it's just like, what? No, I really do think about this a lot. And I think that's why some of these anastomoses don't work. But I think that's why J pouches are prone to getting pouchitis, because things are just sitting there. But I think that's why most patients with Crohn's disease, 70% have Crohn's disease of the terminal ileum, which is right before the colon. And there's a valve there that a lot of times is closed to allow the body to kind of reabsorb whatever it needs to reabsorb, whether it's fluids, electrolytes, B12, folate, all these kind of things before it lets it go into the colon. But I think it's that, especially the things they're putting in the food these days, I think really must be part of it. That when it's sitting there, it's what makes the contact between these foreign materials, whether it's in the food, the pesticides in the food, whatever the case may be, is in contact with the intestine for longer, which is why it causes inflammation. So one of the other areas that there's one of these sphincters, one of these narrowings that can open and close, is from the stomach going into the small intestine. And so kind of the other area it is sometimes is in the stomach. The thing is, I think the stomach is it's almost indestructible in many ways. So I think that's the reason that it's so rare. And we really need to know if someone truly does have, Crohn's of the stomach, what is the best therapy to be treated with? And I think these days, right after prednisone, there was kind of a lull. And then it was Remicade, which was invented at NYU with Dr. Vilcek, who was a Holocaust survivor. And so he invented Remicade in the late 90s. So that's the oldest biologic. And so these days, if someone has upper GI Crohn's, it's Remicade. And very rarely do we have to operate. And that was kind of my article was, okay, well, if you do have to operate, what kind of operation are you going to do? And a lot of times simply bypassing that segment is all you can do, because things are so inflamed. And in that part of the body, there's so many, that's where the pancreas connects, where the liver connects, everything is in that one area. And so luckily it doesn't happen often, but sometimes if someone does need surgery, what do you offer the patient? And even more kind of scary is Crohn's of the esophagus, because now it's in the chest. So now, it's even kind of harder to deal with that. But, I wish we kind of knew more. And honestly, it was something that I worked a lot on. And when I left Cleveland Clinic, kind of, passed the torch. But now that you bring it up, I really think I still have a lot of friends there. And I really think truly when we're done with this call, I'm going to reach out to them and see if we can kind of keep working on that. Because you're right. We need like an update on that. We need to know what the best treatment is for upper GI Crohn's.
Well, thank you for doing that. That's awesome. This is a super wild card question for you. So I've heard about this, but it has not come up on our show before. But when would somebody get a colon transplant and why?
So a lot of times it's the small bowel. So our good friend Michael from 11 Health, he had, and may he rest in peace, he died a few years ago, a wonderful man. He had Crohn's disease and a lot of repeated surgeries, and he had a small bowel transplant. And so that's one of those things. If someone has multiple resections and jejunal-ileitis, which is kind of, in the middle of the small intestine, seems to be very aggressive. And if someone has multiple resections, and that's why every little centimeter counts, and that's why the stapled anastomosis is really, it bothers me that if there's not enough, someone's going to essentially be on TPN, and that's their only, they have short bowel. And what's defined is, there's different definitions, but 100 centimeters with an ileocecal valve, so some part of the colon, or 120 centimeters without an ileocecal valve. So it's not a lot of bowel left, so there's not enough absorption. And if for some reason you can't be on TPN, then they do a small bowel transplant. But just like any other transplant, rejecting the body from rejecting the transplant involves a lot of medications. And sometimes those anti-rejection meds can cause, lymphoma and a lot of other issues. But the long story short, if someone is truly suffering from short bowel syndrome, that's when you get the small bowel transplant, team involved. It's a major operation. And it's something sad, like the success rate's like just over 50%. And so, again, as a surgeon, right, it's everything we can do to think 2 and 3 steps ahead so that doesn't happen, because you never know, if the difference is 20 centimeters, then, that's 2 small bowel anastomoses stapled that you excise. That's the difference right there. And so again, thinking 2 and 3 steps ahead and that's why people get a small bowel transplant.
Okay. Thank you for that. I've been curious about that for a bit. Okay. I remember the other question I wanted to ask you, but I'm going to need your help for this. So there's the 2 different, so you're in J pouch. Your first stoma is just direct, goes out, right? Second
the
stoma is the one.
endoleostomy.
What's the one that looks like kind of a knuckle?
A loop.
Loop. Okay. So the one thing we have heard on this show from from multiple J pouchers is that loop ileostomy sucks.
She's
like,
big.
Yeah.
So as somebody who this is your bag, baby, like this is what you do, like how do you make that the best possible stoma when you know it's like the really terrible one?
You're right. It's never, no matter how good you make a loop ileostomy, it's never as good as the end ileostomy. However, I think, in the way I was taught, and I kind of do things the way my mentor does things, who did it the way his mentor does things, which in many ways was the way his mentor did things, which is this guy, Rupert Turnbull, who literally invented the loop ileostomy, literally. And so how he does it and how he reversed it and all these things, we kind of, it's like an old trusted technique. It's nothing fancier. It's not some fancy stapler. It's kind of just a pair of scissors and, and some sutures. And so when you're making this loop ileostomy, thinking ahead about how you're going to reverse it, right? Always thinking 2 and 3 steps ahead. You almost want it to look like an endoleostomy. I think too many people make the loop ileostomy almost look like what's called like a double barrel. So you can kind of see both lumens or both holes. But when we make, you really want to make a good loop ileostomy, someone should really have to look at it and be like, is that a loop ileostomy? It looks like an end ileostomy, because that means that the effluent, or, the stool that's coming out of the proximal end, or the top part typically, is majority of what's there. And that other end is almost being diverted simply by, it's not 50-50. It's like 95-5. So most of what's there is that proximal end. And so I think that is the biggest thing. And because that is the way you can get it to look the most like a circle, or not like a figure of 8, because that is very difficult to cut the wafer. And then even when you're using the, like, I love those little, I call them the little circles, but those little wafers, those donut looking things, like even if you're like playing modeling clay and like trying to, it just doesn't work. So I think the key is, and we also use a stoma rod. A lot of people are against that, but they're against it because you don't need a stoma rod if you do the way that the Brook ileostomy, as Brian Brook invented this. If you do the Brook ileostomy the way he did not describe, you do it in a certain way, which messes up the way you will reverse it. But if you're doing that darned stapled anastomosis, so the stapled ileostomy closure, it doesn't matter to you, because that part's going to be excised, which again is losing a little bit of bowel. But my point is, you do it differently, knowing you're not going to have to deal with, it's like you're leaving a party and like, you just, whatever, it's a mess. You're not dealing with it, right? And so you don't have to think so much about how you're going to reverse it, because you take an extra bite back on the intestine, and that like keeps it up. So the people who do that go, oh, I don't know why you need a stoma rod. I don't even use one. Well, we're comparing apples and oranges, because the reason the people who really do IBD surgery use the stoma rod is to keep the stoma up, because we don't have that extra bite. And the reason we don't have that extra bite is because we don't want that extra bite there, because we're going to unbrook it. We're going to unfold it and just connect the 2 ends and not resect it. But by flipping it up in a certain manner and using the rod, we're able to make it that 95% proximal end and only 5% distal end. So it's about as close as you can get to an endoleostomy, even though it will never be as good as an endoleostomy. There's certainly bad loop ileostomies.
That sounds lovely compared to what I had.
I'm sure yours was perfect, but those are all.
I can assure you that it was not. I can assure you it was far from perfect. Actually, it was 6 months of not good.
Yeah. It's all those little details, right? So the attention to detail, all these little things that make such a difference. You have one opportunity to do it right.
Okay, I'm going to ask you a really off the wall question now again. So you're welcome. Talk to us about all of the music that you do. You mentioned you play 5 instruments, or you did at some point? Yeah,
when I was younger, I was pretty cool. My father was a doctor, but he played the drums. And so I learned how to play the drums watching him play the drums. But my mother grew up playing the piano, so she got me some like very stern, like she was, not that she has to be Russian, but she just was Russian. And she just made me do like the waltz on the piano. And I was like, this is so boring. I was like 10, And so I stopped playing. It was a big argument, but I said, I'm not playing piano. And so I was playing the drums, and I was pretty good at the drums. I taught myself, but I could play. And years later, a few of my friends played piano, and they always played these cool songs. Like I remember one of my friends played the Cheers theme song. Dun, 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 dun. I was like, oh, that's cool. Like I want to learn that. My other friend was playing like Billy Joel, who's from Long Island, and I'm from Long Island, so that's like a big deal. And I was like, I want to learn that. And it turns out they have the same teacher. So then I, years later, said to my mother, I want to take piano lessons. And so I started taking piano lessons, but then I really got into like guitar. And when you play guitar, the banjo is very similar to the guitar. The bass is very similar to the guitar. So once you start playing the guitar, you're kind of learning these other things. Then you're learning the piano at the same time. And, there's chords in the piano and you're like, oh, it's the same as the guitar. Then you start to take the piano music and you're playing on the guitar and vice versa. And then you got a bunch of friends who play music. And next thing you know, that's what you do after school. Everyone plays an instrument. And so I got really into it and I would write these songs and we kind of, we would, in like high school, we would travel around on the weekends and we'd play in like these bars that,
that's called a band.
Allowed.
Just in case
you
were wondering, that's called a band.
It's true. It was pretty cool. But we couldn't even get into these clubs. They would look at us, be like, the bouncer would be like, what, are you even pretending to get into this club? And we're like, oh, no, we're the band. And so I wanted to be a musician. I think music really was there for me when I was a kid. I thought that was, I think everyone goes through those phases, your mind is expanding and you're trying to figure out who you are. And music was wonderful. And I thought, I could be a musician and I could help other people with my music the way other music helped me when I was a kid. And I really thought I was going to be a musician. But my grandmother, as we spoke about, my grandmother, one famous day at lunch convinced me. I remember we had a big fight. I came home. So I actually played lacrosse in college. So I was like a lacrosse player and played music. And, I studied like only as much as you had to. And I was like, oh, I'll be like, no offense to anyone who's listening who's like a advertising major. But like, I was like, oh, I'll do advertising. That's cool. I was like, because then I'll like write jingles. And I went to lunch. It was like a few days after like my freshman year ended. And I went to lunch as like a lacrosse playing musician who's an advertising major at like 12 o'clock. And like by 1 o'clock, when we were done with lunch, I came home. I was like out of the band. I was now a biology major and I was pre-med. My mother was like, what the hell happened at lunch? And I was like, I don't know. It's what and really what my grandmother said to me though is, it's great. If you're a musician, you get to help people. Great. But what if you don't make it? What if you don't help anyone? And I that was the way she said it. It was all I needed to hear because I thought, what a life not well spent. And she said, every day as a doctor, you get to help someone. And my entire life changed and I have not regretted it at all. I mean, I'm sure I'd be much cooler as a musician, but now I teach my kids how to play but I do think, how can you practice to be a surgeon when you're 16? Like, what are you going to be extra smart? Like, that's not all that goes into it. There is a technical skill behind it. Right. And so, how can you practice to be a surgeon, when you're just a teenager? Well, how about, figuring out how to play the drums and the piano and the guitar and how about doing something tactile with your hands, whether you're an artist, that
dexterity.
Yeah, it actually is important,
Yep.
And so I look back, I don't think I would have done it differently. I think, I'm actually a lefty, right? But you're always living in a righty world. So like a lot of things you do are ambidextrous. I actually operate righty most of the time, but sometimes you operate lefty, and especially with robotic and laparoscopic surgery. I think, music's a lovely thing. And I play a lot of music in the OR, always very calm music, but I think it's important. I think music is important. And there's something about music that everyone brings people together. I think that's a wonderful thing. And there's a lot of dexterity, as you said, that goes into it. But yeah, I play a bunch of instruments. And now my oldest son is a pretty good drummer. My middle son is a pretty good piano player. And my youngest, who's only 4, is like a rock star. He has his little guitar. He strums and he sings on the microphone. It's so funny. But they have a little Partridge Family band. And it's pretty good. They're getting there.
I'm going to take the show on the road. I just know.
They better make us some money. No, no, but like I have to give my wife credit. In our basement, we have a piano, an upright piano, a full drum set, amps, electric guitars, a bass. And then in our main floor room, called the piano room, there's a grand piano. There's other acoustic guitars. From our time living in the city, I had an electric drum set. So then on our the floor that everyone sleeps on, whatever, the second floor, in my older son's room, he's got a full electric drum set. And I have a guitar in there just in case we want to jam. So I got to give her credit. She's this wonderful, neat, normal person who's stuck with me and my 3 sons, just constantly making noise. And I give her a lot of credit for putting up with us, to be honest.
She doesn't play an instrument?
No, but she used to be a dancer and she's got very good rhythm. And so sometimes she'll hop on the tambourine or that little shaker egg. And she's good. I'm telling you, she's good.
That's been so much fun. Thank you so much for agreeing to be on the show. Honestly, obviously, so many IBD patients have surgery. The percentage of IBD patients, I mean, you know this, every year that you have IBD, the likelihood that you're going to have surgery goes up, exponentially. So you coming on the show and sharing your passion and expertise with us is just,
well, I do think
grateful.
a lot of surgeons are pretty scary, at least in the word, even, no one wants to see a surgeon. And then the problem is if you see the wrong surgeon, then everyone's super scared to ever see another surgeon because that one surgeon, was so stern and said, you're going to need, surgery, and left the room. You're like, oh my God. I think the surgeons who specialize in IBD are usually very, very human and care about, their families and their patients all the same. And a lot of them, like even, our cell phone numbers and personal emails, and like call us if there's a problem. That's why I think it's important to kind of get out there and like, hey, don't be so afraid. Not that you have to see me, but don't be so afraid of seeing a surgeon. It doesn't mean you're going to have surgery.
That's right. So not everyone is like you, who is an IBD surgeon. And from personal experience, if you see someone who is not awesome, then just see someone else, because that's what I had to do. I had to change surgeons mid J-pouch surgery, and that's fine. You might have to do that sometimes. That is just the fact of life. It's not specific to IBD. It's just how life works and how doctors work. Everybody's different. So it's not the end of the world if you do have to see a different doctor, a different surgeon in the middle of your surgery journey.
Yeah, it's your life, right? Don't feel bad. It's important. It's your life.
Yeah.
And so you have to do it. I tell people, get a second opinion. I think be wary of the surgeon who says, oh, you don't need a second opinion.
Thank you for saying that. Be wary of the surgeon, and I will add doctor, that tells you not to get a second opinion. I feel like that is true. I don't want to digress because we will go down this rabbit hole, because that is a pet peeve of mine. It is such a pet peeve of mine. So I am going to ask our wrap-up question, which it's actually 2 questions for professionals. What is the one thing that you want our IBD patient community to know? And what is the one thing that you want other IBD medical professionals to know?
Just so the patients know that we really are all day and all night long trying to, come up with a cure or try to come up with a way to do things better. We really are. And just kind of hang in there. I think we're making in the past few years, a lot of advances. And, I used to be a pretty good golfer. When no one needs surgery anymore, that'd be fine with me. That'd be absolutely wonderful. I would love to, working towards like putting yourself out of business is perfect, because I hope that's the case. And so to the patients, we hear you, we know kind of what you're going through, and we really are just trying to help. To the healthcare professionals, I mean, I just think people need to, have the mentality of fighting back like the system. I think the system wants you to see as many patients as possible, as quickly as possible, and just say, screw it, and you have to work with them, but, you have to be true to yourself, and not every patient can just be a 15-minute visit with 2 minutes to document, and then you go to the next patient. That's just not how it goes. And I think, when the hospitals understand that, the insurance companies will have to adapt. I mean, every patient you order an MRI on, you're going to be on the phone with the insurance company saying, oh, why do you need the MRI? Well, because why not try an X-ray? Like an X-ray? That's not even, what are you even talking about? I mean, you could have said CAT scan, and I would have said, that's a good question, but here's the reasons we can't do a CAT scan, but an X-ray, and they like, have you tried just thinking of not doing it? You're like, no, that's also not an option. But we have to like stick together, because if, the patients and the doctors really stick together, and the other, the PAs, the NPs, the respiratory therapists, the dietitians, the stoma therapists, everyone else, if we all stick together, then, we're stronger than these insurance companies and anyone else who's trying to kind of take the humanity out of, it really bothers me when everyone's like, oh yeah, computers will do everything, and AI, and robots. I'm like, you're missing the point if you think this is about efficiency and, cookie cutter out. That's not how it goes. This is about, it's quite an honor and a privilege to take care of someone. You're not just taking care of them, you're giving their family your word also. And so this is about as human as it gets to take care of someone. I think every person you operate on, just as a surgeon, it's like a child. There's a piece of you with that person, because for the rest of your life, you want to be responsible for getting them back to their life. And so you want to do everything possible to make sure they're going to be as good as they can be. And so that's, I think, to the other healthcare people, we just have to stick together and bring the humanity back in healthcare.
Amen. And also, thank you for making Robin and I both cry laugh off camera and off mute. It's have you considered not?
No, that's honestly all true.
Also an X-ray. How does
the X-ray? That didn't happen to me. That happened to a friend of mine, and it was like, wait, what? You're like an X-ray that like clearly they don't know, right? They're just whatever, they're reading some script that says like, and it's like there's only one rule, like just refuse everything. And it's a lot though.
Just rubbing your hand over
Have you tried magically wishing? Yeah. Do you feel a bump? Have you checked for bumps? Like, yes, we checked for bumps. It didn't. Have you checked for them twice? Yeah, we checked for them. Jesus. We checked.
Lord. Oh my God. I'm sorry.
That's true.
Dr. Schwartzberg, seriously, you are a joy and a treasure. And I am so happy we've gotten a chance to talk to you and meet you. Thank you for coming on the show. Thank you for being such an amazing surgeon to all of our folks and for deciding to specialize in inflammatory bowel disease and sharing yourself with us. So thank you everyone else for listening as well. And cheers.
Cheers, everybody.
Thank you. Hi, this is Dr. David Schwartzberg. If you enjoyed this episode, please rate, review, subscribe, and share it with your friends. Thank you.